Greetings. My name is G.S. Raju. I'm on faculty at the University of Texas, MD Anderson Cancer Center, as the chair of the World Endoscopy Organization Webinar Committee. It's my special honor to work closely with Dr. Ripici, Dr. Decker, Dr. Emura to organize this first webinar looking at the global impact of COVID-19 on endoscopy services. Let me take this opportunity to introduce Dr. Fabian Emura, President of our World Endoscopy Organization. Dr. Emura currently serves as the head of gastroenterology at the University de La Sabana, Bogota, Colombia, where he trained over 250 gastroenterologists from the Americas in advanced endoscopy. The Emura Foundation has undertaken National Gastric Cancer Screening Program for people of lower socioeconomic status. In 2020, he received the American Society for Gastrointestinal Endoscopy International Service Award. Dr. Emura.
Thank you, Raju. Greetings from Bogota, Colombia. It is now 8 in the morning, 2 in the afternoon in Milan, and 10 p.m. in Tokyo. As the president of the World Endoscopy Organization, I am proud to bring with me the goodwill of our entire society and a wish of health from all our officers, chairs, and members to all attendees from all over the world. WEO is very honored having a remarkable panel of educators, scientists, and 4 world-known speakers to conduct this first WEO webinar on the global impact of COVID-19 on endoscopy services. It is also my privilege to chair this webinar with 3 outstanding WEO chairs. Dr. Raju, Chair of the WEO Webinars Committee, Ale Repici, Chair of the COVID-19 Committee, and Evelyn Decker, Chair of the CRC Screening Committee. I believe education is the chief cornerstone of society progress, and I'm proud that WEO is conducting this course despite challenging times we are all facing with the COVID-19 pandemic. Finally, I want to welcome all attendees and those who will watch this later using our media channels. Thank you.
So my name is Alessandro Rebici from Milano. I'm also glad to welcome everybody to this meeting. It's a privilege to serve WEO as the chairman of the COVID-19 committee. And I'm so glad that we got this meeting under Christmas time. Christmas this time will be very different, it will be unique. And I think we need also to be different and unique for our work. We need to work more united and to look to different perspectives. And so glad that we will share today a global view of what is going on with COVID and how we can recover with COVID and endoscopy procedures. So I wish all of you the best for this webinar.
So let me first introduce our first speaker, Dr. Sravanthi Parasa. Sravanthi is a practicing gastroenterologist based in Seattle. She has specialized training in epidemiology and biostatistics with special interest and experience in large database analysis. Sravanthi has done exceptional work and published a lot in a very short span of time. And I must say, she will be a star to watch. She's currently working to identify risk factors for poor prognosis among COVID-19 patients. Sravanthi's topic for today's webinar is risk of infection and global impact on endoscopy. Sravanthi, welcome.
Thank you so much for the introduction, Dr. Raju, and it's my honor to be a presenter at this conference. And I'm really excited that this was one of the first the COVID was one of the first chosen topics because it unites us globally in terms of how we manage this. And I'm just going to quickly talk about what I'm going to talk about today. So my topic is the risk of infection and global impact of COVID-19 on endoscopy. And this is my disclosure. A brief overview, I'm just going to bring some numbers as to where we stand in terms of global impact of COVID-19 on all of us in terms of the number of infections, deaths, hospitalizations as such. And then I'm also going to focus mainly on impact of COVID-19 on endoscopy services. I might not touch much about the drivers of change as to what is actually caused the impact because I will leave that to the panelists for discussion. So this is a graph that I pulled off of the Johns Hopkins COVID-19 tracking resource. The cutoff is on December 2nd, 2020. And this is actually a global representation of different countries. So of course, I won't be able to focus on all the countries that are listed and all the graphs that are up here, but I will just focus on the top three here, which you can see. One is the green line, the orange line, and the red line. So looking at what these lines basically mean, the green line is United States. That's one of the highest global highest burdens of COVID-19 globally, and we are increasing in huge numbers rapidly as well. As you can see, the first wave as we define it was somewhere from March 2020 over up to maybe June 2020. You see that little hump up there. That's when we think that's the first wave. And around June 2020, most of the economies across the United States have opened up either from phase 1 through phase 3, depending on which state the economy was based in. But the lowest was in June 2020. And slowly after reopening the economy, you see that there was a significant increase in the number of cases, probably peaking around August in midsummer. And then slowly peaking down again. But again, we see the huge slope of this graph up here, where we are currently experiencing the highest number of COVID-19 cases, even compared to the first wave, second wave, and what we call the third wave now. The slope continues to increase at this current time. Now, the second graph, which has the highest number of COVID cases, is Brazil. And it was quite quiet in the first phase when the United States was having significant impact. And then you see a slow increase in the number of COVID-19 cases. And probably the peak was around in late July, August, and then it's slowly trending down and again caught up with the rest of the world in slowly increasing number of cases through winter. The third graph that I'll be talking about is India, again, a major economy. So again, quiet until May 2020 and slowly started seeing increase in the number of cases. And the first peak or the peak that we see so far has been in mid-September and October. And there is a significant decline in the number of cases since then. Probably one of the only economies that is not seeing a increase in the number of cases in winter. So that's what I have. And I also pulled up the numbers from New York Times as of today morning. Looks like the total number of cases for COVID-19 is 65.9 million globally, and about 1.5 million deaths globally as well, which is a significant 11% increase over the past, on an average in the past 14 days. So that's where we stand in terms of COVID numbers, at least in some of the major economies. Things are not looking great at this point. So my focus is to just talk about the impact of COVID-19 on endoscopy services. I know there were multiple surveys out there, some of them conducted by independent countries, but I'm going to present the data from the JICE-1 survey, what we call the Global Survey of Impact of COVID-19 on Endoscopy, which was deployed by WEO in mid-April. So this is again just to give an overview of what was happening in the first wave of COVID-19. Obviously, there's been a lot of change and we are learning a lot more over the last 9 months about this condition as well. So it was fairly a simple study with 16 questions. We collected data on basically the location of endoscopy units, baseline volume of the procedures performed pre-COVID over a period of 1 year, and what was the percentage of the baseline volumes of procedures during the COVID-19 first wave. The way I define it as is from somewhere from February to May 2020. We also paid attention to the type of PPE that was used during this time period to get some insights regarding supplies and how that might affect the risk of infection and impact on endoscopy services. So briefly, the survey was sent on April 23rd. We got the responses back and closed the survey on May 12, 2020. And this picture here actually is an ArcGIS, which is a Geographic Information Systems image showing the participants in this survey. The participants, when I say they're not independent endoscopists, they're independent endoscopy units. So there were a total of 252 endoscopy units that participated in the survey. As you can see, they're widely distributed across the globe, and I really thank all of you who were able to complete the survey, because that gives us important insights into what's going on, just not at a specific nation level, but at a global level. So I apologize for this busy slide. These are the participant characteristics by continent. So when we stratified the results, we basically stratified it by the continent level as well as the volume of procedures that were performed. Hopefully it's not too busy because I know all of you are in front of the screen, so you can see each and every number clearly. But just to summarize the first part of the slide, the characteristics of the centers that participated in this study. There were a total of 255 endoscopy centers, and this is the distribution of the different centers based on location. And on an average, they performed about 2 million procedures prior to COVID-19 in the past year, and had about 2,800 endoscopists in total, representing these 255 survey participants. And 3,000 endoscopy nurses and about 1,300 endoscopy technicians. This is spanned across 55 countries and 6 continents. So you can see that the average amount of endoscopy procedures performed in this survey was about 8,200. But the median was about 5,000. It's not represented here, just for the sake of clarity. And in terms of the number of endoscopists in each unit, it was about 7. That's the median. And then the median number of endoscopy nurses in all these units is about 6.5. So there's no half there, so I'll just say 6 to 7. And in terms of the number of endoscopy technicians, there were about 3. So that's the basic characteristics of the participants. Now, I'll go into the volume of endoscopies performed pre and post-COVID in a second, but I just wanted to briefly touch on this question where we asked, did any of your endoscopy staff have COVID-19 infections? And 34 centers basically responded at least one of their staff member, which could be an endoscopist or a nurse or a technician, tested positive for COVID-19, and that was about 13.5% of the total survey participants. As you can see, most of them were from Europe. About 17 of them actually reported at least one endoscopy staff or personnel having a COVID-19 infection. But what you see is what percentage of the COVID-19 infection required hospitalization. It's about 7.9%, but the median is again 0. So suggesting that most of them were one from Africa and Europe and probably Asia that reported they had some endoscopy staff have COVID-19 infection. None of them had any mortality, which we're very fortunate about. So that is the risk of infections in COVID-19 among endoscopy staff. Now, going to the next slide. So this is a brief depiction of the volume of endoscopy procedures during COVID-19 pandemic during the first wave by continent. As you can see, this blue bar is all endoscopy procedures. The red bar is upper endoscopy, which we clubbed it as EGD, EUS, and ERCP procedures. I apologize for the typo there. And then the green bar is colonoscopy and sigmoidoscopy. On an average, what you would notice is there's significant decline in the total proportion of volume of endoscopies performed across the globe during the first wave of COVID-19. Mostly it's below 20%. Only Oceania, which is Australia and New Zealand, did not report a significant drop, still less from what it is compared to baseline, but not as prominent as noted in the other continents. So the average was, this is the median value. The average was about 17% drop in overall endoscopy procedures, meaning the total number of endoscopy procedures performed was 17% compared to baseline of 100%. So that correlated with the proportion being about 18% for EGD, EUS, and ERCP, and about 15% for colonoscopies and sigmoidoscopies. Again, this is a different view of how we can look at the data. So we all know that volumes of the procedures performed can have an impact on subsequent volumes, especially during a pandemic, as well as patient care and stuff. So we kind of classified the information into 3 tertiles, less than 2,500 procedures performed at baseline as tertile 1, and 2,500 to 7,000 as 2, and greater than 7,000. As you can see, the number of procedures performed in high volume centers is still a little bit higher than those performed in the lower 2 tertiles. So the conclusion here is patients or centers which have high volume performing at baseline continue to have a little higher performance of endoscopy procedures. Now, I'm just going to quickly turn around to the use of N95, because as most of you might remember, this was an important concern in terms of getting the supplies and was also an important contributor to not performing endoscopy procedures at full capacity to some degree. So we surveyed the use of N95 use in upper endoscopy only at that time, because the guidance from most of the societies, GI societies, has been to use N95 for upper endoscopy procedures, which is a little different now. And we see that on an average, it's about 75% used N95 masks for upper endoscopy. And this is the breakdown based on the continent. Again, we see Oceania seems like they've been a little resistant to COVID-19 because of the geopolitical reasons that we know of. So they've been using N95 for upper endoscopy at 40%. South America has reported 100% use of N95 for all upper endoscopies, and North America about 91%, and these are the rest of the continents as well. And these are statistically significant. So on that context, I also wanted to touch upon the endotracheal intubation piece because there was some data out there to do endotracheal intubation for patients to prevent aerosolization and infection among endoscopy staff. I just wanted to report that 11.8% of all upper endoscopies underwent endotracheal intubation. For most centers, they did not differ from baseline reasons as to why a patient needs to have endotracheal intubation. This is based on this is the N95 use in upper endoscopies based on volume of procedures performed at baseline. As you can see, the p-value is not significant, and that means there was no difference in the use of N95 based on the volumes. It looks like everybody was around 75 to 79% on an average in terms of using N95 masks. Now, I'm going to briefly, before I conclude my presentation, talk about or introduce the concept of why the volume of endoscopies performed has been decreased during the first wave of COVID-19. And probably this will give us insights, and as we have learned more during the last 9 months as to how to deal with the pandemic moving forward in terms of endoscopy volumes. So the first reason as to why endoscopy was kind of shut down, for lack of better terms, during the first wave was for resource conservation. When I say resource conservation, it's just not PPE. Of course, that was a major factor as well, but also to have human staff like our nurses and physicians to be available for emergencies to take care of COVID-19 patients, as well as hospital beds and other resources that are needed to take care of these patients. The second thing that was a major driver is availability of PPE, and I know several GI societies have worked towards helping practices acquire PPE so that they can run their practice smoothly. The third important driver, which has been significant, is patient behavior and their attitudes towards more elective procedures during the pandemic. And since the first wave, there has been a lot of education that has been going on from the GI societies as well as independent practices to emphasize the collateral damage from COVID-19 if patients do not seek care that they are supposed to get. So I would leave that up for discussion as we move on later in the day for panel discussions as well. Before I conclude, I just wanted to bring to your attention the JICE-2 survey, again deployed by WEO, and it's the global impact of COVID-19 on endoscopy. And this is the second part where we are assessing how different countries and different economies have basically dealt with reopening of their endoscopy units post the first wave of COVID-19. So if some of you are willing to participate, this is the link, and probably WEO can send a reminder message as well. Thank you very much for your attention.
Thanks, Sravanthi. Excellent presentation. So I think now is my turn to present Dr. Gralnek from Israel. Jan has a unique career because he served in the board of the American Society of Gastroenterology and Endoscopy. He's now serving in the board of European Society of Gastroenterology and Endoscopy. So he's bringing a real global view of endoscopy. Thanks, Jan, for joining this meeting.
Ale, thank you very much. I want to thank the WEO leadership, specifically today, Professor Emura, Raju Ripici, and Evelyn Decker for this kind invitation. It is now almost 3:30 in the afternoon here in Haifa, Israel. And I've been tasked over the next few minutes to discuss the impact of COVID-19 on training in endoscopy. So in about April or May of 2020, this was really at the height of this first wave in Europe. The European Society of Gastrointestinal Endoscopy conducted a survey of its membership of almost 3,000 members, trying to get an understanding of what was going on in their endoscopy units regarding the number of procedures, resources, lack of PPE, impact on training, etc. So these data that I'm going to show you right now in the next couple of slides are from really the first wave that was occurring here in Europe, which was quite severe. So one of these questions was, how much has your endoscopy workload been reduced by the COVID-19 pandemic? And we just heard a little bit about this already in our first talk by Dr. Parasa. And not surprisingly, what we found here in Europe was that about 30% of the endoscopy units had a reduction of at least 50 to 75% of their endoscopy workload. An additional almost 50% had about a 75 to 99% reduction in their endoscopy workload. And this was due, again, as we just heard from, for a number of reasons, whether it was that the staff was not available, that there was PPE that was not available, that it was patients who were scared to come to the hospitals. It was also following the guidelines at this point that only urgent or emergent endoscopies were being performed. Most units were canceling any type of an elective endoscopy procedure. Another question was, for what indications do you still perform endoscopy during the COVID-19 pandemic? Again, as I just said, it was really 70% were performing only for urgent emergent endoscopy procedures. Or they were also describing these as on a case-by-case basis to be high priority types of endoscopy. So really in this first wave in Europe, there was a huge impact on, there's a huge decrease in the number of endoscopy procedures. And not surprisingly, this translates into an impact on our trainees in endoscopy. I'm going to show you a few studies. There have been a number of surveys that have been done in various countries that have looked at the impact of the COVID-19 pandemic on the training in endoscopy. So this first one I'm showing you was published in Frontline Gastroenterology. This is from Romele. It is from an academic center in Augsburg, Germany, that looked at the impact of COVID-19 on endoscopy training. And really what we're seeing here is you can see in March and April, and we're looking at the second bars here, sort of this darker orange or red and darker blue. This is looking at various endoscopy cases and endoscopic ultrasound, is that you can see that as compared to 2019, there starts to be a slow decrease in March, and there is a rather precipitous drop off in April in terms of the training opportunities for the young endoscopists. Again, if you look here more specifically, if you look at March, there was about a 40% drop off in March of 2020 as compared to 2019. And in April, it was even more significant. It was a 90% drop off in the endoscopy cases that were being performed by endoscopy fellows or endoscopy trainees. This is another study that was published recently in Gastroenterology. This is by Keith Xiao, that looked at a similar survey of endoscopy training in the United Kingdom, whether that was supervised endoscopy training or independent endoscopy by trainees or fellows. They looked at various endoscopic procedures, including upper endoscopy, colonoscopy, ERCP, EUS, and upper GI bleeding. And again, what we're seeing here, if you look down below as pre-COVID and then during COVID, both
¿Qué pasa?
Is somebody can turn off their microphone? There's a little bit of a background. Pratik Sharma, can you turn off your microphone? Okay. Pratik, if you're listening, I think your microphone's on. Can you turn it off? Thank you. Okay, so, and what we saw here, if we can go back to the previous slide. So this is a study from Xiao, and what we're seeing here actually is that looking at pre-COVID and as well as COVID, no matter if these were supervised endoscopies or independent endoscopies by endoscopy trainees, there was really a significant drop-off in all types of endoscopic procedures performed. These data are not overly surprising, in my opinion. There's an additional study outside of Europe. This is from Australia by Prince and colleagues that really shows that about 30% of endoscopy units or the trainees in terms of their endoscopy training, 100%, 30% of the trainees, 100% of their endoscopy training was stopped completely. Another 34% said that anywhere from 75 to 99% of their endoscopy training was stopped. An additional 20% had at least 50 to 75% of their endoscopy cases halted. So this, not surprisingly, leads to concerns on the part of the trainees that they were very worried about being adequately able to develop their endoscopy competency. So they began to look at alternate sources of education. These are also data from the survey from the UK by Chiu. What they found is that about 30% of trainees went to social media-based type of education. There was about another 16% that seemed to read journals more, endoscopy-focused journals, hoping to get some insight into endoscopy training. There were others that used online courses from various GI societies, which included the American Society, the ESGE, the WEO, and other societies or national societies that were providing guidance. Others took up what was described as distant learning from other institutions. And there was actually almost 40% who reported that they did not access any type of alternate educational resources for their endoscopy training. So there are a number of problems and barriers to endoscopy training during this global pandemic. One, there's the whole issue of training versus service. There have been a number of places around the world because of the huge number of patients that trainees in endoscopy have been taken out of the endoscopy unit, were taken out of the gastroenterology department, and have been deployed to other medical units, intensive care units, or the emergency department to cope with this huge crush of COVID-19 patients. I can tell you at my own institution, at least thus far, this has not happened, but our endoscopy trainees definitely were not performing endoscopy in the spring and the early summer. As usual, things have started to get back to normal, but as of this point, nobody has been redeployed. There is, of course, the diminished volume of training procedures. We limited the involvement, many places limited the involvement of fellows during the endoscopy procedures. This may have also been impacted by the limited amount of PPE. So in other words, it was decided that senior physicians would do the examinations because they want to conserve PPE and they do not want to have an extra endoscopist in the room, specifically the trainees. So the trainees were out. And then, of course, as I talked about, there were so many postponement of non-urgent procedures or elective endoscopies that just the workload dropped, and that was often performed mainly by the senior staff. So we should all really realize that GI endoscopy, however, is not just a technical discipline, it is also cognitive. So what can we do? Well, when you have lemons, you can try and make lemonade. And there are potential alternative endoscopy training options. I've mentioned some of those before, and trainees have already turned to some of these options, but there is online e-learning. I can tell you from the organization which I serve in, which is the ESGE, we have online training for members using my ESG tutor. We also have now almost every other week ESGE webinar Wednesdays, where we present various topics on endoscopy. There are also, of course, online many endoscopy videos and technical training videos, whether this is through YouTube, whether this is through Twitter or Facebook or other social media. There's also the now becoming more and more popular Scoping Sundays, which many trainees follow and tune into. If you have an animal lab and there are animal models available, this can be used as an option. This is not common. Also, as well, the use of endoscopy simulators can be used in place of doing endoscopy on real life patients. And there are a number of sites on the internet that can be searched out that show you how to make homemade endoscopy simulators that you can use if needed. We can allow, if there's enough PPE, allow trainees to participate in selected endoscopy cases. But I think there's another question I'll be interested to see if this is asked and answered in our discussion period, is there are now places that are considering whether we need to extend training periods and consider 2020 as almost a lost year of training, or at least a partial loss. And do we need to extend the training period for these trainees because they're just not going to be able to ramp up high enough to get adequately trained in their endoscopy skills? And I think that answer remains to be seen, but something I think we do need to consider going forward. And I'm going to stop there, and I look forward to the discussion. And I want to thank the WEO leadership again for inviting me to participate. It's been an honor. Thank you.
Thank you very much, Professor Gralnek, for this wonderful presentation that we will be discussing later. It's my honor to introduce to you Professor Han-Mo Chiu. He is a clinical professor of the National Taiwan University College of Medicine. He also will be succeeding Professor Joseph Sung as the Asian chair for the WEO CRC Screening Committee. So with great pleasure, I announce him, and he is going to discuss with us the global impact of COVID-19 on colorectal cancer screening. Professor Chiu.
Thank you, Evelyn, for your kind introduction. So it is my great honor to be invited to these wonderful webinars. And today I would like to talk about the global impact of COVID-19 on colorectal cancer screening, with special emphasis on how we can do to mitigate such an impact. So my today's talk will start with the description on the impact of COVID-19 on colorectal cancer screening activity worldwide, then followed by how can we manage the screening backlog during the pandemic by setting priority, what resilient action that we may take during the pandemic, and how can we adjust our strategy to adapt COVID-19 pandemic and the social distancing measures, and how and when can we restart the screening activity, and finally, what would be the new normal look like after this pandemic. So this slide shows the time trend of 3 common cancer screening in the US in the past 3 years and the comparison with this year. And as you can see on this slide, the appointment for screening for cancer of the cervix, colorectal, and the breast were down between 86% and 94% in March compared to average volume in the past 3 years before the first COVID-19 case in the US. What will happen if cancer screening is paused? It may lead to decreased detection of cancers, delayed diagnosis leading to progression of the disease with resultant upstaging of the cancers, and it may also delay or interrupt the subsequent treatment. And this modeling study revealed that there will be tremendous number of excess deaths from breast and the colorectal cancer in the US in the upcoming 10 years owing to the post-cancer screening by COVID-19. Take FIT screening as an example. Almost every step of screening logistics is affected by the pandemic. The negative motivator for FIT screening include the fear of being infected by COVID during the process of obtaining and returning FIT kit, or during the process of colonoscopy or hospital visits. It is also possible that people are persuaded by the doctor or hospital not to go for screening. Previous study from the US and Taiwan have already shown that delay in diagnostic colonoscopy after positive FIT was associated with increased risk of colorectal cancer and advanced stage cancers. It was shown that if the waiting time exceeds 6 months in Taiwanese study or 10 months in US study, that the risk of colorectal cancer or advanced stage cancer will significantly increase, which may also likely increase the risk of colorectal cancer deaths. WEO Colorectal Cancer Screening Committee started to collect and monitor the change of worldwide colorectal cancer screening activity from this March, with some of the screening program being paused since the wake of COVID-19, whereas some of the regions have restarted screening after a transient pause, but in inconsistent pace. During the period of communicating with many screening programs, the expert working group also noticed that there were some observation of the impact of the COVID-19 pandemic on colorectal cancer screening, such as occupy healthcare resources, screening being ignored or considered as low priority by the authorities, shortage of medical or paramedical staff involving colorectal cancer screening during the pandemic, and the public anxiety about the risk of being infected during colonoscopy or not being arranged for colonoscopy after positive fit, and so on. Here are some of the examples. In UK, during the pandemic, the reduction in weekly procedure volume compared with pre-COVID was 97% for bulk cancer screening program, colonoscopy, and 99% for bulk cancer screening program, flexible sigmoidoscopy, and the proportion of missed colorectal cancer was as high as 72%. In the US, in the UCLA health system, the utilization of colorectal cancer screening declined drastically in the beginning of the COVID-19 pandemic, largely driven by drop invasive screening modality. A concomitant increase in non-invasive screening modality was observed, though not sufficient to compensate for the overall drop in screening. In the Netherlands, during lockdown, the number of colonoscopy reduced by 45%. After lifting of lockdown, endoscopy volume started to return to normal, except for colorectal cancer screening, as you can see here. In Korea, the trend of fit uptake was in parallel with the COVID-19 pandemic, which decreased drastically from February to April, and then gradually caught up in the summer season, but declined again in October after the start of second surge. In Fukui Prefecture, Japan, the screening activity was totally stopped during April to early June this year and restarted in late June. However, the future of colorectal cancer screening remained full of uncertainties. In Taiwan, where COVID-19 was considered as contained quite well, screening activity was still affected by this global pandemic, probably due to public anxiety. As a result, 16% less colorectal cancer were detected as of July compared with that in the corresponding timing in 2019. We conducted a simulation assuming long-lasting pandemic for years with persistent 15% reduction in fit screening coverage rate and a bit lower colonoscopy rate compared with the ordinary rate in the past years. The projected results show a more than 6% reduction in the effectiveness in terms of colorectal cancer mortality reduction over 10-year span by the screening program. And such situation may become worse if community outbreak happen in Taiwan. It is therefore not difficult to imagine in areas that are more badly affected by the COVID-19, there will be a tragic increase in colorectal cancer and the colorectal cancer deaths in the upcoming future if the pandemic does not cease. COVID-19 is the first pandemic in history in which technology and the social media are being used on a massive scale to keep people safe, informed, productive, and connected. At the same time, the technology we rely on to keep connected and informed is also ironically amplifying an infodemic that continue to undermine the global response and jeopardize measures to control the pandemic. There were more negative sentimental information transmitting in Twitter during the COVID, and the exponential curve of the spread of the information, which is just like the transmission of the virus. To avoid this, it is of utmost importance to let the public aware of the real situation of COVID pandemic in the community. Therefore, we held a press conference together with the Taiwanese government in July to advocate the importance of receiving colonoscopy after a positive fit, by emphasizing that 1 in 20 fit positive cases may have colorectal cancer. The importance of timely colonoscopy to avoid progression of cancer, and most importantly, tell the people that cancer won't stop to occur because of the COVID pandemic. As a consequence, the colonoscopy rate gradually caught up in summer season and recover to its usual level by now. We may also consider to adjust our screening strategy from direct colonoscopy to fit best two-tier screening approach, or combine use of fit and risk score system, which can significantly reduce the colonoscopy demand, but still on good performance of detecting advanced adenoma or cancers. And we may also consider to use postal mail to deliver fit kit to absorb the need of hospital visit. And the telemedicine is another approach that we may use to keep connected with the people during the pandemic and use it for consultation, such as evaluation of the feasibility of screening, notification of the screening test result or pathology report, or scheduled colonoscopy. Into the constraint and uncertainty of endoscopy capacity during the COVID pandemic, it is very important to set the priorities. So those with overdue fit, symptom with the suspicion of colorectal cancer, or those with very high risk of colorectal cancer should be prioritized. Meanwhile, we should also take into consideration the age and the comorbidity of the people, and the previous history of screening or recent negative fit. And we can also make use of the fecal hemoglobin concentration to set the priority. Quantitative measurement of fit is mostly only used to determine test positivity, but it was well studied that fecal hemoglobin concentration was also closely associated with the likelihood of having advanced adenoma or cancers. Accordingly, we can use it to stratify the priority of colonoscopy during the COVID pandemic if endoscopy capacity is very constrained. Some specific indicators, such as the percentage of delayed screening invitation, the interval from positive screening test to colonoscopy, the rate of cancellation or rescheduling of colonoscopy, or the change of stage distribution, could be used as the new screening indicator to help mitigation during the COVID pandemic. And when can we restart screening is of great concern, and the objective index would be helpful. Recently, lifting social distance index was proposed, and if we look at the formula of this index, then we can know that if less number of cumulative COVID-infected cases, more COVID cases recovered, and the decreased number of mortality, then this index will decrease as well. If the value of this index is greater than 1, this means that it is still necessary to maintain social distancing because the rate of COVID-19 spread still outweighs the affordable capacity of hospitalization and the critical care. By using the data of SARS in Taiwan in 2003 and the MERS in Korea in 2015, we can see that this index may be useful to guide restarting of screening. By means of using this index and the personalized risk profile determined by the risk score or fecal hemoglobin concentration, then we can tailor screening for those who can be benefited and should be prioritized. Of course, we have to continuously monitor every important aspect, including the situation of pandemics, the status of screening activity, the number of backlogs, and so on. So finally, what would be the new normal of colorectal cancer screening after the pandemic? Perhaps people may reconsider the advantage of two-tier screening approach by using the non-invasive test as the primary screening modality, the advantage of organized screening strategies, and to implement telemedicine or even mobile unit into our screening setting, considering the possibility of the outbreak of the next emerging infectious disease. Thank you very much for your very kind attention.
Thank you, Professor Chiu. It's a beautiful talk. I really learned a lot. And let me take this opportunity to introduce our next speaker, Dr. Mark Pochapin. He's the Scholz Leeds Professor of Gastroenterology and the Director of Division of Gastroenterology and Hepatology at NYU School of Medicine. And he is our immediate past president of the American College of Gastroenterology. Mark is an educator at heart. He has received over 30 teaching awards, including the Humanism in Medicine Award. He was also recognized recently as the 2019 Master Clinician at NYU School of Medicine. Mark's topic is the role of GI societies to maintain safe practice and support physicians. Mark, welcome.
Thank you so much. It's such a privilege and pleasure to be part of this WEO presentation, talking about what the WEO and other professional societies represent, which is us, and us being at our best. It's an absolute privilege to talk on a global scale because I think our health and our wellness is our common denominator of humanity. And I think all of us in the medical field recognize that and also recognize the privilege of being able to care for others. So there are a lot of leadership principles that can be recognized in the setting of a crisis, because crisis really represents two components, as well shown here: danger and opportunity. And we're all brought together in a crisis. And here, a crisis to our health is a global crisis. It's all of us. And as difficult and as horrific as this virus has been, there's also some opportunities for us to look at what we're doing and perhaps do it even better, as you've heard from some of the previous talks. So what do we need to recognize as leadership principles that our professional societies really need to reflect? Because our professional societies are us. It's just a way of bringing us together and helping us do better. We have to be authentic and transparent, and that's particularly true in our manuscripts. In the time of COVID, manuscripts were coming out in draft form practically, and not going through the same rigor of peer review normally. They were getting brought out so quickly. So it was really important for us to be very transparent about the early component of these publications. They needed to be frequent, clear and definitive, and serious, but optimistic. And what I mean by that is there's going to be information coming from professional societies from all different aspects. There's going to be emails, there's going to be webinars, there's going to be publications, there's going to be guidelines, but they have to be in a way that help us and help us move forward, recognizing that there are things that we know, but by and large with this virus, most of the things we did not know. And that's why we had to focus on the success, recognize the outstanding efforts, but also recognize what we need to learn. Looking at everything we do and say, how can we do it better? I think the fact that we're having a meeting, a global meeting over Zoom, is something we wouldn't even think about a year ago. But somehow we've been able to figure this out and do it well, and what a great meeting this has been. And then learning from each other. And I think that's where the WEO and other organizations, particularly on a global scale, are so helpful. So for example, in New York, as I was president of the ACG, we had speakers from Wuhan, from Italy. In fact, Ali Rapisi was our speaker from Italy, telling us what they went through and how what they learned can be utilized for us to do better. So we don't have to reinvent things, we can learn, particularly about PPE is very, very helpful. And actually having Dr. Rapisi come to the ACG board and talked about us about the experience that he had in his group and the data he had put together was incredibly helpful. And now what we've learned from New York, and one of the things we've learned from New York is that social distancing, masks, and containment can work even when you have such a surge like we had in New York City. So the professional societies in the US, and I'm going to focus on the US societies, were really unified. All the presidents, in fact, Klaus is on this panel, and David Greenwald was the president-elect of the ACG, and Bishar Omri. We were all together as individuals, but also representing our professional societies to make sure that the messaging was coming with a clear and consistent tone. guidelines of what to do with PPE and testing were so important. People just didn't know what to do, when to close, what to wear, how to test, and when to reopen. And that's why I'm going to tell you now, because I had an intimate look at how the ACG functioned, what we did at the ACG. But again, not saying one is better than the other, just how we all function as professional societies and why they're so important for our members. Well, we had a Board of Trustees weekly Zoom meetings, and we really made sure that we came together on any major topic. There was rapid review, as I mentioned, the literature in our journal, the Red Journal, was one that in print couldn't come out quick enough, but the electronic versions could get things out very, very quickly in preprint form so that we could get information. And then, as we heard, social media became so important to be a window into some of these publications. And I know, for example, Dr. Rapisi would put up publications very quickly that I would look at, and I would be able to see a new publication is out, let me read it. So these frequent updates. Then I'm sure all of you who are ACG members became sick of our communications, our emails, the video messages that I personally made, but it's important to keep frequent communication. We know in crisis management, communication is key. Special webinars, we were having them weekly, sometimes 2 or 3 times a week. And then we had a virtual grand rounds, which was really focused again back on GI type of topics, recognizing that we all love gastroenterology and we still need to learn our own profession discipline. I would also say that we had some webinars on COVID-19. If you're a gastroenterologist, being called into the front lines to treat COVID-19, not GI, but actually as an internist, as a medical doctor. And in New York City, all of us had to go in on the front lines, including our trainees. And that's something we could talk about, the effect of trainees in New York City. They were actually in the ICUs, and there was quite a bit of effort to try and get everybody who was on the front lines, also the psychosocial help to deal with the stress and the trauma. This was our member alert that came out from the 4 US societies. And this came out early in March when we realized that we're really going to need to shut down. So it came as a member alert, came from all the societies. And then once we shut down, we had to figure out how are we going to reopen. And this is the ACG. Now, everybody had their own group. This was our roadmap to resuming endoscopy, put a group together of different type of practice backgrounds, different parts of the country, to make sure that we had a real understanding of what everybody was going through, because clearly what we were going through in New York City was very different what they were going through in the Midwest, in the South, and in the West. And now New York City, although we're seeing a slight increase, is nowhere near what's happening in the rest of the country in the United States right now, where we're seeing tremendous rise in certain areas, particularly in the Midwest. This was our PPE decision tree, and I will say that by and large, this is the overall consensus. Really depends on 2 things: availability of PPE, availability of testing, and prevalence. The prevalence is really important. Of course, we have to define what prevalence is, and that's a little different, and I'll show you those differences. But in low prevalence, that's considered, and that's a community prevalence. This is not a country prevalence or a global prevalence. In low prevalence, for patients who are asymptomatic, by and large, we feel like surgical masks are okay. And Dr. Rapisi and his colleagues have a lot of data on surgical mask use and mask use, PPE use in Italy. But overall, and the WEO put out a nice statement in June in Digestive Endoscopy, talking about the same type of concept where low prevalence and asymptomatic patients can probably be fine with a surgical mask. Now, generally, we lump all endoscopy as a single unit, but when you really split them out, it's really the upper endoscopy we're most concerned about as a potential aerosolizing procedure. And then in high prevalence, you really need to use the N95 in high prevalence area. Even if you test negative, what we've learned is the asymptomatic spread of this disease is really what's keeping it spreading. And what's surprising us time and time again, that people can be positive, but actually still spread this and then develop symptoms later. Now, if you're in a low prevalence area and you have access to N95s, and I think that again comes to the access to PPE, people are generally using N95s, and that's overall the general recommendation, but it's not a must. The Infectious Disease Society of America, I think, put this nicely, that if patients have, or if we have PPE available and patients are asymptomatic, just use the most advanced PPE. And if PPE is limited, that's where testing asymptomatic patients may be helpful. And also, if there's PPE available and you are able to wear an N95 at all times, then perhaps no testing is necessary. And the AGA came out with 4 guidelines. Now, their guidelines, very interesting, were based on asymptomatic prevalence. Now, we know when we talk about prevalence, we talk about what percentage of people have tested positive. These are people getting tested. The AGA actually brings it to asymptomatic, and they give a formula to calculate that. It's tough to figure out that formula because not all the data is present in real time. But the bottom line is intermediate prevalence, which they talk 0.5 to 2%, again, asymptomatic, requires some type of testing strategy. Recommendation 2 for low prevalence says no testing is necessary. Recommendation 3 in high prevalence says no testing is necessary. And recommendation 4 is not to use serologic testing. This is a nice graph where you could see abundant PPE on the top, abundant testing on the right. So the green abundant PPE and the green abundant testing, but all roads in either high prevalence or low prevalence lead to no testing. And the PPE is really based on the availability of whether you have N95s for all procedures. So if you have abundant PPE, even in low prevalence areas, this guideline is saying use an N95 because you just might not know someone could sneak through. But if you don't have the PPE, if it's limited, then for upper endoscopies, consider using N95 and high or use N95 on high prevalence, or don't do the procedure. But in low prevalence, using surgical masks should be okay. And this is the formula to calculate asymptomatic prevalence. Again, this is based in the US, but it's not so simple because these numbers are not available for every area and they're not updated in real time. So access to PPE becomes critically important. And we saw a nice slide that different countries have different access. And the more access we have, the less we might be concerned about testing. And that testing, again, is dependent on availability and the type of testing. You know, testing has different sensitivity and specificity. So knowing your community prevalence is important. Also knowing whether things are going up or coming down. And we saw in the previous talk, again, the graphs in the US, unfortunately, we're heading up, but in other parts of the world, it's either leveling off or coming down. And that might, again, change our recommendations. So coming back to the professional society leadership, we talked about authenticity, we talked about communication, the publications, and then reflecting the publications in the social media, these guidelines of how we can actually address our needs for PPE and testing are really important. Recognizing that we also have to be present for the fear and the anxiety that not only the mental health professional has, but our patients. And we saw what the impact is on patient concern for screening. Patients might not feel comfortable getting a colonoscopy, going to a healthcare facility. As professional societies, we need to take that up too. And recognizing how grateful we are to have each other, to have this webinar, to have our professional societies there, being our voice and also our platform to really put forward what we all need to know and what we need to project. So I want to end with resiliency. There was what was called the Miracle on the Hudson, not far from where Dave Greenwald and I live in New York City. And Captain Sully, who landed this jet on the Hudson River, saved every life, not a single life was lost. When they asked him, how did you do it? He said, in many ways, as it turned out, my entire life up to that moment has been a preparation to handle that particular moment. And that he had to force training and calm. And I think all of us had to really step up. We had to be the best we could, but in many ways, our entire life's experiences, and particularly as leaders within professional societies, have been really preparing us for this moment. And when we act at our best, Phil Katz, one of our past presidents, said miracles occur when everybody performs at their absolute best. And I think professional societies and the members that they reflect really can perform miracles. And I think we did. I think the WEO in this webinar really reflect that. So I want to end with this slide. This is an artist, Joseph Lee, who I think captures it perfectly, that no matter how strong Superman is. No matter how much he can fly, he can't do what health professionals did and take care of all these patients with COVID-19. And we are all in this together. As I mentioned, such a privilege to be part of the medical profession, which recognizes as health is our common denominator. So thank you very much. And again, really appreciate the honor of being part of this webinar.
Thank you so much, Mark. I really appreciate this. We've learned a lot, and I really admire your leadership and the leadership of ASGE and AGA and all the societies around the world for helping us pull through this COVID. Let me request Dr. Fabian to introduce the panelists.
Thank you, Raju. It is my great privilege to introduce the remarkable panel of educators, scientists, and leaders from major endoscopy societies are joining us for this WEO webinar on global impact of COVID-19 on endoscopy services. I want to start with Asadur Tekmedian. He's the chief of the digestive endoscopy department at the Asociación Española in Uruguay. Asa is the president of the Inter-American Society of Digestive Endoscopy, SID, and he's also the Goodwill Ambassador of the Aurora Forum. David Greenwell is the director of clinical gastroenterology and endoscopy at Mount Sinai in New York City, and professor of medicine at the Icahn School of Medicine at Mount Sinai. David is past president of the New York Society for Gastrointestinal Endoscopy and currently serves as president of the American College of Gastroenterology. Haru Inoue is professor and chairman of the Digestive Disease Center at Showa University in Tokyo. This year, Haru was the recipient of the WEO Master Endoscopist Award and is currently the president of the Japanese Gastroenterology Endoscopy Society, JGES. Klaus Mergener is affiliate professor of medicine at the University of Washington in Seattle and received a PhD in molecular virology from the German National Cancer Institute. Klaus serves as the president of the American Society for Gastrointestinal Endoscopy, ASGE. Nagi Reddy, chair of the Asian Institute of Gastroenterology in Hyderabad, India. Nagi is past president of the World Endoscopy Organization, fellow of the American Association for the Advancement of Science, and is currently the chair of the steering committee of the Third World Congress of Endoscopy, ENDO 2022, to be held in Kyoto, Japan. Pratik Sharma is professor of gastroenterology and chief of endoscopy at the University of Kansas. He's the chair of the WEO Esophageal Disease Committee, and Pratik serves as the world leader of WEO's global surveys in COVID-19 and endoscopy. And last but not least, Verly Coupé is associate professor at the Department of Epidemiology and Data Science of the Amsterdam University Medical Centers and the head of the Decision Modeling Center that focuses on model-based evaluation to optimize cancer prevention and care. So welcome all. And I wanna ask Alexandra to pull the first question and also to be the chairs and Raju to lead from now on. Thank you.
Thank you, Fabian. Thank you so much. Let us take this poll question so that it will help us discuss some of the issues that we face. So what is your prediction of endoscopy services in your area in the next 6 months? No change, reduction by 30 to 50% from pre-COVID, increase as we have to deal with backlog, and not sure. Please take the poll. I think it will be helpful for all of us to see what's happening around the world. And the poll is anonymous. So. We'll give about another 5 seconds, and then Alexandra will show the poll results. All right, so let me read the poll because this is not going to be recorded on the live stream if you want to post it on the YouTube. So what is your prediction of endoscopy services in your area in the next 6 months? I think 44% feel that it will increase to deal with the backlog. 30% feel that there is going to be 30 to 50% reduction from pre-COVID, and 22% feel that there's no change. All right. So let me ask the panelists a couple of questions to start the discussion. One thing is, as physicians, we are not only investigators and educators, going through what we have gone through. Where did we go wrong to have peak after peak? And what could we do as societies to prevent this in the future? So let me open this thing to the panel and maybe start with Mark, his thoughts on this. And what I would recommend is let the panelists open up their videos and their unmute so that we can have a live discussion.
Hi, thank you. And I think what we're doing right now, this WEO webinar, is what we can do as societies and as a community of gastroenterologists globally. And that is discuss, talk about what we're learning from each other and put it forward so that we can actually utilize the information and come up with revised guidelines and recommendations as we get more information. I mean, one of the things about this virus that is so unique is that we're really learning about it in real time. We had no idea what this virus was about. When we talked about the early recommendations, we didn't really know about this asymptomatic spreading of the virus, for example. Now we're taking that into account. We didn't know how well PPE works, but we know PPE works if we use it correctly. And we also didn't recognize the incredible stress, not only in the healthcare workers, but on our patient population, worried about screening and what effect that's going to have, not just in the immediate term, but in the long term. So I think, what can we do? It's exactly what we're doing now, is come together, create recommendations, and get them out to our members.
Thank you, Mark. Let me hear Klaus's thoughts on this.
I like the fact that, to your question, where did we go wrong and where did we go right, Mark answered on the positive side of things first, because I think that does need to be emphasized. We've done a lot of things right. The other thing that I think we've done right over time, and that going forward, hopefully we'll continue to emphasize. We've talked a lot in this webinar about gastroenterologists and our patients. We haven't quite emphasized as much the role our staff has played. And in a specialty that always runs a risk of doing assembly line work as we do more and more and more endoscopies, I think COVID has allowed us to pause and recognize the human element of what we're doing, not just vis-a-vis our patients, but our staff. And you know, when Mark talks about frequent communications, we mean to membership, but also in all of our units, frequent huddles, frequent team meetings, making sure we understand how our staff struggles, feels, how we can help them. So I think there's a lot that we've done right in that department.
Nagi?
Yeah, Raju, I think we actually didn't do anything wrong. The problem was the virus hit us fast. Hit us very hard. And by the time we came to know what happened, it was already a month late. And I mean, it was very early that endoscopy started. I think Alice Pepper came very early on in February itself of what precautions to take. And as we're evolving, we came to know that there was a lot of information that was like the older information that hand washing was important was replaced by masks are more important. So even if you look back now in endoscopy unit, the masks were the ones which were saving us rather than all the whole PPEs and all. So I think it was very important that this evolution in the knowledge was occurring. And this was the learning process. And there's nothing, even retrospectively looking back, I don't think we could have done anything different. And I think endoscopists all over the world have done a great job in terms of guidelines that have come from different societies, getting together to put this together. And if you look at infection rates in endoscopy units all over, as Sravanthi presented earlier, it isn't as much as it should have been if you actually did take all these precautions. And about 13% is not too bad. And mortality, I mean, severe infections have been very low, mainly because of the masks. I think one of the things that we did very early was this masks. So I think actually even retrospectively, we didn't go wrong at any stage, and I don't think we can improve on this. That's what I feel.
David, what do you think?
Yeah, let me focus on what we did right as well. I think the thing that we did most right was communicate with each other. We learned from each other, and that was so smart. So learning what was going on firsthand in Italy and getting some information from Wuhan straight away, and then in the United States, learning how each different part of our country was dealing with issues really helped collectively, come up with solid information that we could then distribute out to our members and our patients. And that was really, really important. Let me tell you one other thing that we did right, which was dealing straight up with the fact that this made endoscopists and our staff anxious. They were worried, they were appropriately fearful. And we were able to produce information. A lot of this comes initially from Ali Rapici again, so thank you, to really tell our staff that, as Nagi was saying, as long as we had the right PPE, we were safe and we could continue to take care of our patients. And that, I think, was a major plus to move us forward as we try to figure out how to deal with this pandemic.
Pratik, I see that your ICUs are full.
Yeah, thanks, Raju. So I think all the current and the past presidents have, nicely summarized what went right. And I think it's extremely important with, and especially in the US, with all the societies coming together and having one common message. Unfortunately, where we went wrong was that the message was not consistent from outside of the medical fraternity. And so if you were to ask what went wrong is, I think that's went wrong. And I think everybody's trying to skirt that issue a little bit for good reasons. And part of the thing is that our patients were getting mixed messages. Is wearing a mask right or not? Is social distancing okay or not? Is this virus for real or not? So that's, I think, if I were to say what went wrong is, I think that's what went wrong. And we have to acknowledge that. Unfortunately, none of us on this call can control that. What we could control, I think we did absolutely right. And I think that's what you're hearing from everyone thus far. And that leads into your question about the ICUs and what's happening in the Midwest. So what Mark and David saw on the East Coast, unfortunately, as the initial rage, I think that's what we are seeing in the Midwest now. And our institution is sending out daily messages about our ICU capacity as well as our bed situation. And I hate to say it, but we're several unfortunate areas of the country were several months ago. So they asked us to not perform any GI procedures which may require admission. So they've asked us to hold off that. All the surgery units have been asked to cut down on one elective surgery every day. So, they're trying to prepare for that. Our ICUs, the census changes every day, but there were days that we could not accept patients from other catchment areas. And so, so I think while things are getting better in different parts of the world for good reasons, unfortunately in the Midwest, we are still lagging behind, and we will see the brunt of Thanksgiving next week, and unfortunately the brunt of Christmas and New Year's in early January, unless we start practicing what the medical community has been doing.
Thank you, Pratik. Let me request Alexandra to pull up Ian's question. This is about training. I think it's an important aspect. So this is about during COVID pandemic, have any of the GI or endoscopy trainees in your department been reassigned to other medical departments? Yes or no? So in the interest of time, we'll just take 5 seconds so that we can move on, because we can learn from all the panelists. Yeah, it looks like about close to half and half actually have been reassigned to other departments. And so, Ian, what do you want to talk about?
Well, listen, the issue here is how long some of these trainees are being reassigned or redeployed, because if it's for an extended period of time, I think there is going to probably have to be some consideration into potentially lengthening their training. If they're gone for 6 months, or even if they're within the department, yet they're not really having the adequate numbers, and I guess that will be known towards the end of their training, their numbers of procedures that they're doing, there may be some places that their training will need to be extended somewhat so that they're adequately and properly trained.
I'm glad that you asked this question, and I wanted to pose this to our presidents regarding what should we do for these trainees who come and say, I've not had enough training. What do society should do in terms of getting their technical hands-on training so that they're competent when they go out into practice, that they feel good about their training? Because the cognitive aspect of endoscopy is being covered on webinars, et cetera, but the hands-on training is still something that we need to address. So Klaus?
Yeah, excellent point. And Ian has given us in one of his slides a nice outline of some of the options, and none of them are ideal. And all of them are problematic. It's not that easy logistically, as we all recognize, to extend a training period. How are we going to do that? What does that mean in terms of certification requirements? What about the next year of trainees, and so on and so forth? The maybe easiest, still very suboptimal version is to try to figure out how to make up some hands-on time during the remaining time of their training, and then supplement it as much as possible with society generated hands-on training, regional hands-on courses that we may want to put on around our country. And we're working on concepts along those lines at ASGE, mobile hands-on training that we might proactively take to various geographies around the country. But excellent question and difficult answer.
Nagi, any thoughts on that?
No, I think it's extremely difficult to compensate in the short period. We lost about 1 year, and for fellows to make it up is going to be extremely difficult. So, it's not also easy to ask them to do 1 more year, because that's wasting another year. But I think, like everything else in COVID, these are difficult things that we can't get answers to.
Let me just add one thing, Raju, if I may. A supplemental measure would be once this year of trainees gets out of their training, to then provide opportunities for their first, second, third year in practice, wherever they might end up, to come back and get supplemental training, which currently is not usually done. So extending their training period in that sense, not in the sense of postponing their certification, but then trying to supply them in the years ahead with additional training opportunities.
So let me ask the society presidents whether this is something that we all think is very important to address, and whether there should be a guideline from the different societies on how to manage this huge number of trainees that may feel that they've not had enough hands-on training, and how to come up with a program for them. I think this is something worth for people to think through. David, any thoughts on that?
Yeah, I think it's an excellent question. I think, getting some numbers and data behind this is really, really important. The training numbers clearly went down. Locally, our trainees were redeployed, as the question was asked before, and they are worried about their procedure volumes. We've paid attention to it, again, locally, by, as our COVID numbers drop, just inserting them more into a variety of settings where they get more experience right now. And that seems to be helping quite a bit. From a society point of view, each of the societies has a training committee. I think this is an excellent topic for them to address, and something that we could come up with suggestions and guidelines on. We certainly have to address the question.
Yeah, thank you.
Raju,
I think Pratik wanted to say something, yeah.
Yeah, Pratik,
yeah,
go
so Raju, just from the program director's perspective, I can tell you that there's a lot of discussion on this on our program directors forum, with all centers coming up with various ways. And I think a lot of this will be locally driven as to what you can do in your institution may not work at another institution. So for example, we were lucky that none of our GI fellows were redeployed, and so they're still within GI. And what I can do in Kansas City is change rotations in which maybe the outpatient clinic exposure decreases, but their endoscopy exposure increases. But for David and Mark, that may not be possible if their fellows are deployed for 6 months in the ICU. They're not within GI. So I think a lot of this, and this has been a discussion point in the PDs forum, is try to make use of your resources. And all PDs, I think, are being flexible in terms of what they can or cannot do locally. And we've tried to increase that exposure to endoscopy. And I think ABIM has also come out, and ACGME, in saying that they'll be lax in terms of not requiring exact number of procedures.
Thank you, Pratik. So in the interest of time, we will take one last question. Alex, can you pull out Dr. Hanmo Chiu's question, please? We'll do this thing fast. I think depending upon where you are, whether you're in Asia, Europe, North America, South America, pick your question. And the question is about, does your country continue or has restarted CRC screening as of now? Yes, never stopped during the pandemic. Yes, partially restarted. No. So pick your own area, depending upon where you're coming from, and pick that poll question. Europe, North America, South America, Asia Pacific. All right, let's see the results. Right, in Europe, partially restarted, almost it's a smaller number. North America, again, partially restarted. About 25% said no. In South America, about 50% said no. In Asia Pacific, again, 50% said no.
So Raju, may I invite Dr. Veerle Coupé
Yes,
from
please.
the Netherlands to comment on all the modeling efforts that are currently being performed on how to deal with stops and what would be the best strategy to reduce the extra mortality we might have from the stopping of.
That's the only reason I wanted to pull this so that Veerle can have the final word.
Thanks.
All right.
Thank you very much, Evelien Dekker, for the question and for the possibility to comment on this. So indeed, like you say, there is an international consortium called the COVID-19 and Cancer Global Modeling Consortium, and we are doing efforts to firstly estimate the long-term impact of the lockdown, the initial lockdown at the beginning of the year. And secondly, we are evaluating potential mitigation strategies to reduce the additional colorectal cancer deaths that are caused by the lockdown and the reduced screening practice. So we are focusing actually on ways to increase the FIT cutoff and thereby control the available colonoscopy resources. So basically tune the FIT cutoff to the colonoscopy resources that are available per country. So it seems actually that if you raise the FIT cutoff, you might, even with an equal amount of colonoscopies as was done before the lockdown, you could at least avoid like 50 to 70% of the colorectal cancer death that the lockdown would have caused without this catch-up strategy using a FIT threshold that is increased. But of course, we will report our findings soon so that they're available for different policymakers. And I think there's other mitigation strategies to study. So I was very interested in the presentation by Dr. Chiu, who showed also some long-term impact projections, I think, based on modeling. So it would be nice to see that other modelers come up with the same solutions and same strategies to see that there's coherence. Thank you for your attention.
Thank you,
Raju.
Yeah,
Raju, just let me just jump in before we leave to ask Haru from Tokyo and Asa from Uruguay their general input and insight regarding either training or CRC screening or the global impact in Japan and Uruguay. I think it's a great privilege to have you here, Haru and Asa. So please, Raju, let's give them an opportunity to share their insights.
Yes, please.
So this is how can I speak?
Please.
Sure.
So I really appreciate all the informative lectures. Of course, it's a balance, so it's very difficult to handle at this moment. Fortunately, still in Japan, the exact number of the COVID patient increasing, but still we can keep the endoscopic walkthrough. So in a Dr. Parasa, she reported that the 50% infectious rate and the in the endoscopy suite. But at this moment, so we have to be very carefully wearing the regular PPE and then continue our working to the patient care. So, but we also have to keep the young doctors keep safe side. So balance is very difficult. But thank you very much. So everybody's great talks.
Thank you, Haru.
Well, thank you very much for the opportunity, and thank you all for the beautiful lectures. Here in Uruguay, we are facing an increase in the cases and the number of cases. We have been dealing very well during the past months, but nowadays we are reaching high numbers. But so I am not going to focus on the situation in Uruguay at this point, and I want to introduce a question for the panel before we finish. The question is, do you believe that this will be a nightmare to tell to our grandchildren, or do you think that this situation will change our practice, our endoscopy practice for the entire future? Maybe Evelyn or Patrick, I want to hear your inputs.
I'm Nagesh Reddy, and I think this is going to be one time. I'm sure we'll pass this once the vaccine is freely available. By end of next year, we'll probably forget everything. The only thing that may continue is this virtual meetings, which probably most meetings will become hybrid now because we're getting used to these virtual meetings. It's much easier and cheaper to organize them. But otherwise, I think our practice, and we don't have to think about our grandchildren. I think children is sufficient.
I hate to contradict an upcoming ASGE Schindler Award winner, but I actually am hopeful that we will not forget the experiences. And I know that's not what Nagi meant, but there's a number of learnings that I think will carry forward beyond just telemedicine, likely becoming more and more prominent and not going back to where we were last year again. There's a beautiful editorial by Tony Fauci in Cell from a few months ago talking about how pandemics become more and more prevalent. So our learnings might serve us well. This may or may not be the last of these situations that we see. It's the first in our lifetime, and we're hoping it's the last. I'm not sure it will be.
Very clarifying, Klaus. Thank you.
So I want to thank all the panelists, and on behalf of my co-chairs, Evelyn, Ali, Fabian, thank you so much. And I want to thank the speakers and the panelists for a fantastic show. And maybe this is a last point that we discussed, as we should have a guidebook for future, how to prepare for a pandemic and how to take an active role in public health. Thank you.
Thank you, Raju.
Thank you.
Bye. Thank you very much.
So much. Everybody stay well and safe.
Thank you.
Bye, guys.
Bye-bye. Thank you.
Thank you.
Thank you.
Bye-bye.
Stay
The
safe.
outbreak of COVID-19 has slowed down some medical treatments. 10% of the healthcare professionals are COVID-19 positive in Western countries. Endoscopy exams are being reduced in capacity or postponed, 54%, due to the lack of PPE protection devices. At Fujifilm, following long research and testing, we've developed a PPE device to reduce droplet spread, the B1 Droplet Reduction Mouthpiece. Our study showed that droplets from patients might be a serious threat and a way of spreading the virus. We compared the traditional mouthpieces to our B1 mouthpiece, and the results are evident.
As R&D engineer for endoscope system, I have two strong desires in the current situation. First is to provide patients with a safe and timely opportunity of appropriate endoscopic examination. The second is to mitigate healthcare workers' risk of infection. The product concept goal is to prevent the infection droplets from the patient during the procedure. Some of the design features are: first, the mouthpiece has two foam layers with C. The foam is designed to reduce the spread of droplets through the mouthpiece. The slits are designed to accommodate different diameters endoscope. Second, the mouthpiece comes with a drape shield for covering the patient's face, and is designed to minimize the droplets spread from gap between patient mouth and mouthpiece.
COVID-19 is again dramatically spreading in the European countries, and therefore there is a very strong need for us in endoscopy to better protect our patients, but also to better protect ourselves. I strongly believe that the new personal protective equipment of Fujifilm might help us by reducing the amounts of droplets during endoscopy procedures.
At Fujifilm, we are committed to improving technologies that support global efforts to confront the COVID-19 pandemic. We will never stop innovating for a healthier world. Fujifilm, value from innovation.
Thank you, Fuji, for your support. Thank you, Fabian. Thank you, Nagi. Thanks, everybody.